Alrighty, we've got folks joining, it looks like still, but it is 12:15, so I'll go and get started. So this is, I think, the third to last talk. We're wrapping up, starting this in April, going through November, so it's been a bit of a journey. So this one's going to be on navigating the driving talk. With this talk, just one disclosure, so I don't have anything relevant there, but I do put on, so I've been involved with these elderly drivers roundtable discussions that were really picking up before the pandemic and have kind of died down, but they still are ongoing. About quarterly, folks meet to kind of how to handle the aging population issue and driving, and that's obviously a complex discussion in and of itself. But we're focusing more on not just older driving statistics, but really as it relates to brain pathology and neurodegenerative disease. And then, I'll have some ideas here about appealing to personal responsibility and liability, and then also how to pursue a proper evaluation, because I think that's important if you need some sort of objective testing to help with that decision tree. And then sort of the last resort option as well. So it is the elephant in the room. It's, the one discussion that I think gives a lot of physicians pause of even making a diagnosis, and this is true too for patients, because in the state of California it was a mandatory reporting. If somebody had Alzheimer's disease, you had to report it to the state, and then what that led to is patients just stopped going to the doctor with memory problems, and they stopped getting diagnoses. So there's a double-edged sword there, right, with that type of mandate. And it's true that, even if you just look at numbers, right, for folks over age 80, at least 20% of them have cognitive impairment. But does that mean that all of them are unsafe to drive? Not necessarily, especially at more mild stages. So it's something to keep in mind. And, the whole goal of this is we're trying to, maximize independence, but safely. And that's a delicate tightrope to walk. I mean, it's a major quality of life issue, as we're all aware. When I tell my patients, these are the things you need to be doing to protect your brain or to slow down the disease or help prevent dementia. It's being engaged, it's exercise, and it's volunteering, it's social activities. All those require, for the most part, transportation to get there. And so, for them, it's sort of this, idea of, how do I meet these goals that you're recommending me, doc? From a statistics standpoint, just to give you some numbers, these lines are divided up into males and females with age along the x-axis. This is just looking at motor vehicle crash deaths per 100,000. And this was from 2018 data. Oh no, I don't want Siri activated. So as we all know, as the frontal lobe is connecting, right, up until age 25, 29, there's a lot of accidents, and more in males and females. This is reflected in a lot of insurance coverage plans, but we see that increase quite a bit as folks get over age 70 as well. And that number really starts to spike back up. Viewed another way, if you just look at per 100 million miles traveled, because usually these folks are driving a lot more at younger ages, driving to work, driving to school, driving to jobs, just per 100 million miles traveled, it really escalates, right? So per miles traveled, we're getting a lot more accidents in this 70-plus-year-old age group. And this is just something that's going to be exacerbated, right? Because we all know that it depends on which projection you look at, but at least doubling by 2030 compared to the consensus in 2011 as far as those over age 70. And so the estimates are that group will then account for 40% of the expected crashes and 25% of the expected fatalities in accidents. And so the most common thing I get back when I start to have this discussion of maybe I'm concerned about memory is, well, doc, I've never had an accident. I've never had a ticket. And obviously that's not the decision tree of when to stop, right? I don't want you to undergo some sort of potentially life-threatening injury before we decide that's not the thing you should be doing. And so the accidents are what we're trying to prevent, and we're obviously trying to prevent that fatality rate. There are different scenarios you're going to run into. I see plenty of patients from rural areas where they have one stoplight in the whole town, right? Or they drive on country roads. Both the patient and family are completely unconcerned with their driving. Now, some of that could be a denial or maybe unawareness, but no one's concerned, right? And so that's a little bit of a different scenario than when the kids are concerned. Hey, we don't even let, or I don't even ride with this individual, right? Or we definitely don't let the grandkids ride with this individual. We're concerned, but they can't be the bad guy, right? They can't be that sort of mediator of taking the car away. So that's really the perfect role for us as providers, to step in and be that bad guy, right? To saying that it is probably time to retire from driving, and these are the reasons why. It is important to follow with these are the reasons why, right? If you're dealing with sort of this maybe potential denial and unawareness, then what I usually will do is at least give some red flag warning signs. So, if a spouse is like, well, I never really ride with them, so I don't know. Then I say, well, please ride with them every once in a while and look out for these things, right? Especially if they're getting lost or if they're not obeying traffic signals, if they're cutting off other drivers, or seems to be having visual spatial issues of straddling lanes, reacting slowly to the environment, using poor judgment, having trouble judging distances, a lot of near misses, getting honked at. So I've never had an accident, but there's a lot of people swerving around me, right? That would be a concern. The one big red flag, and really that cuts to the point. Are certain individuals not allowed to ride with this person? If not, why not? Accidents and tickets are obviously a potential red flag as well, especially if it's a change for that individual. So I sort of use this talk to also incorporate a few more neurodegenerative disease learning points, right? So in my practice, my sort of area of concern, or like which patients am I most concerned about? It's folks with posterior cortical atrophy, which we'll have a slide on what that is. It's Lewy body disease, it's frontotemporal dementia. And then probably fourth down the list is our typical amnestic short-term memory Alzheimer's disease patient, Parkinson's disease, more of a young onset Alzheimer's disease, and then maybe a language variant, a primary progressive aphasia variant of neurodegenerative disease. But in order of convincing, frontotemporal dementia folks are classically individuals that have lack of insight into symptoms. And so the frontal lobe is not working, and these folks can be the hardest to convince that they should no longer be driving. This can be true for Alzheimer's patients, though, especially if the right side of the brain is involved. So usually they'll have more behavioral symptoms, or we can even see frontal behavior variants of Alzheimer's disease. And then my younger onset folks, they're so independent otherwise, it's pretty hard to convince them sometimes that this isn't a good idea. I try to focus on what the brain does and maybe tie that into why I'm concerned. So one of the big ones back here is the back part of the brain, the visual cortex, right? And so that leads us into posterior cortical atrophy is really just, it's actually one of our only well-named neurodegenerative diseases. It's talking about posterior being the back part of the brain, cortical meaning the cortex, and atrophy meaning shrinkage of the brain, right? So it makes sense that the back part of the brain would be having troubles. And so this scan is just an example of a glucose PET scan for a patient where the right back part of the brain was more involved than the left. And you can see it looking at the back part here. What's interesting is, so about 90 to 95% of posterior cortical atrophy cases are due to Alzheimer's disease, meaning the amyloid and tau proteins are depositing in the brain, and it is Alzheimer's disease. It's just it's an atypical variant. It's a visual variant of Alzheimer's disease where the tau, this is a tau PET scan, just really deposits in the back part of the brain much more than, say, the memory structures or other parts of the brain. We can do brief little testing. So I just did this yesterday with a patient because we were concerned, could she be having some early visual issues? And you can show them a big A here, right? So you'd want each one of these individual on a different PowerPoint slide, but I just pull up the PowerPoint slide and I show them this. Patients with posterior cortical atrophy, or what we'll call PCA, they see all these little E's, but they can't see the A. So it's kind of like being able to see the trees, but not the forest. And the issue is information is coming into the eyes, but it's not being registered in the back part of the brain accurately, and they're not able to see the whole picture. I've had patients describe it's like looking through a spotlight. So they're able to see little parts of the picture, but not the whole picture. On overlapping objects, I've had a patient say they saw an 8 here, or a turkey head. I've had someone say an elephant trunk, but not able to see that it's part of a larger teapot, right? Especially in a complex environment with overlapping objects. And so this is, I talked about looking through a straw, right? Or looking through a spotlight as that's all you really need to drive in the state of Kansas. You just need something beyond 20 degrees field of vision. That means you're not legally blind. It's totally unclear why specifically this was changed in 2014 in the state of Kansas. The previous requirement before that change was 110 degrees, which is just slightly above the national guidelines. And so that's your unsettling thought of the day. Write your congressman, right? From a Lewy body disease perspective, so very similarly to my PCA folks, it's the back part of the brain. So we have visual spatial difficulties, but a good 75-80% of my Lewy body patients also have Parkinson's symptoms because it's caused by the same protein in the brain. And so they're going to have also issues with processing speed and reaction time. When we test visual spatial function, having them draw a cube and a clock, I get a lot of different varieties in my clinic of what those look like. But these are two different individuals with Lewy body disease. And similar picture where the back part of the brain is where patients are having troubles utilizing glucose much more than the front part, looking here versus here. And this is a kind of a classic representation of what Lewy body disease looks like on a PET scan. From a frontotemporal dementia standpoint, the problem is the frontal lobe. So from an anatomy standpoint, what does the frontal lobe do? And here's an example, especially the right frontal lobe, that tends to represent a behavioral variant of FTD. And so here's just two different examples of that. So the frontal lobe is important for, it's kind of your filter, right? That's one thing that it does, but it is responsible for judgment, problem solving, processing speed, executive function, decision making, impulsiveness. So all those can be issues. We've had instances of hearing about, there's been a lot more road rage or a lot more cutting people off or getting a lot angrier with driving, and that's the frontal lobe changing, right? And some of that leads to very dangerous driving behavior. From an amnestic component, I've shown you this slide a couple times now where I always focus in on these hippocampus structures. And this is just showing different stages of Alzheimer's disease affecting these hippocampus structures. What's important to know that, so the hippocampus is important for storing new memories, short-term information, asking a patient to remember things 5 minutes later, a list of words, but also right in that area along the parahippocampus and the entorhinal cortex is where your place cells are. So it's a highly connected region of navigational abilities, right? So if patients have used GPS and they're able to still, navigate that system, they actually can do fairly well with driving early on. But what they're going to struggle with is less familiar locations, and then eventually it's going to start to pare down to even the local areas where their local maps that were very strong are going to get affected. And that's also why patients, when they move to a new location and they've got troubles in the hippocampus, they can't form new maps, right? So it's storing new memories. That's the major problem there. The young onset folks, so they have more of actually many of them can have hippocampal sparing disease, especially for the first number of years. And it's really this frontoparietal brain network. It's the working memory network that's more affected in young onset cases. And so those folks, it's not necessarily a mental maps problem, but it is a problem with multitasking. They cannot multitask at all. And so if they're having to navigate somewhere and also focus on driving, they're not able to do that. But if they're able to have the GPS tell them where to go and they focus on driving, they do relatively well as long as they're not distracted. And so that's really the main takeaway point here is they cannot multitask. There cannot be distractions. They can't take phone calls in the car. We even tell them to turn off the radio They just have to focus on driving. And so they can do reasonably well with no distractions, at least for the first number of years of that disease. For language predominant symptoms, so this is actually this is showing you an Alzheimer's disease variant that affects the language network in the left side of the brain. So the parietal lobe and then the left lateral temporal lobe is kind of right along the language network. And these folks can also be hippocampal sparing early on. And this is almost always, 90-95% due to Alzheimer's proteins, just a different brain network and a more atypical presentation. The issues with this, especially if they drive alone, is if they have more advanced aphasia, or if they have a head injury and they've already got aphasia, then they're going to be even more aphasic for that short term. And can they communicate an emergency, right? And so that's a concern with their driving more than any other aspect of the driving machinery in the brain. I think it's important to have some sort of materials, especially if you have a population of aging patients, and particularly if you see patients with dementia, neurodegenerative diseases, having some material out, because it may be the family's been thinking about it, but they don't have any avenues to even bring up those discussions. So this is one that we've had in our clinic, and I remember having up at Mayo Clinic, family conversations, family, starters, right, for this discussion. It's good to have that material out there. I personally have a little shorthand that I utilize when I at least caution against driving. And so this is a long-winded way to say certain things, but I usually, especially if I've done bedside testing and I say, I'm concerned enough about the driving. There's no clear cutoff that says you're not safe to drive, but especially if we're dealing with something like Alzheimer's disease or Lewy body disease that is going to get progressively worse with time. It's not a matter of if, but when, right? And so at least thinking about that and that idea of what's the plan, right? What's the plan for retiring from driving is important. And ideally, you want to say, we want to maximize your independence, but as safely as possible. So I usually fall back on, look, I'm concerned based on your cognitive exam here. But I'm not on the road driving with you. That's the disadvantage I have. I recommend a formal driving evaluation. That's really our gold standard of is this individual safe to drive or not? And I utilize the liability standpoint too, because if I have said, I don't think this individual, I have major concerns about them driving, and then they get an accident, then that's potentially a liability issue, right? And they're usually pretty understanding of this reasoning, right? I think there is many folks that get that idea of, they don't want to harm anyone else, and they get this reasoning as to why I'm recommending this. The Alzheimer's Association has a driving contract out there, so I personally haven't used it. I think it's a pretty good idea, but I'd be interested if anybody in the audience has used it. Essentially, it is indicating, right, that individuals may not recognize when it is time to stop driving. And that's just the nature of the disease. And they may not remember that they agreed to this contract, but this contract addresses both of these things, right? And it really does highlight that we need to be thinking about this much earlier. We can't be seeing folks when they're in moderate severe dementia and then having a driving discussion with them, right? That is part of our whole mantra of trying to detect things sooner, get things in place sooner, be planning for things sooner. This is so important for patient care and progression. So when we think of a referral for driving evaluation at earlier stages makes sense. This is a proactive strategy, right? Some sort of comprehensive driving evaluation, usually by a trained occupational therapist, is what we recommend. And for many of these folks, yeah, they're safe to drive, local areas, local radius, not during nighttime. But that at least starts that process, right? Of there's gonna be a time where maybe I need to retire from driving. And that's the biggest key here. For some patients, I'd say it's a minority. They very well recognize the anxiety they get with driving. They say I'm done. But that's a minority of patients, especially for my male patients. For the goal of these again is to maintain independence as long as we can, but we're also dealing with something that's going to get worse with time. So usually the driving folks that we work with, they'll recommend a repeat test in a year, right? Or if there are concerns sooner, that is going to require repeat testing. And it's very possible that this evaluation leads to recommendation to retire from driving. So we utilize, you can look up online. There's a national database of occupational therapists that at least are trained in driving evaluations. We personally utilize one in Overland Park. I don't even order a driving evaluation here at KU because it's done virtually and it's a lot more paperwork. And I don't really enjoy the virtual evaluation compared to an on-the-road driving evaluation. So I really trust the evaluation here at the PAM Health Rehab Hospital. From the state of Kansas perspective, it's not a mandatory report state, but certainly you can report. And so, anybody, it's a confidential report. Basically, what does that look like? And that's not just a physician, right? Anybody can send in a letter of concern to the state. This can be done by the driver's license exam stations, by law enforcement, by somebody in the community, by family members, and obviously us providers. For families that, as far as like kind of last resort things, controlling key access is one thing. So it could be that they really are set on keeping a set of keys, right? That's just part of what's in their pocket, but make sure that none of those keys start the vehicle. That's one option, to just make sure they cannot drive when you're not aware of it. Sometimes people get in the car at nighttime. Another option is to basically install some sort of switch, right? That you only know where the switch is that can at least start the car. It's not able to be activated by just simple plugging the key in. And then really out of sight, out of mind is sometimes what works for people. That's what worked for my grandfather as he progressed. It was always, if the car was in the driveway, there was always a question of where are the keys, buddy? And then once that car was gone from the driveway, that slowly dissipated over time as far as those questions. So that is obviously an option too. So I'm going to pause there. I'm going to mention one other thing. I mean, if you're thinking about, and I'll look at what the chat shows, but if you're thinking about this idea of, well, these driving evaluations sound good. How much does it cost, right? That's one thing. It's not cheap. It's like $400, at least for the ones that we recommend, a very good, thorough evaluation. I think that's a systems problem more than anything else. I think it doesn't make any sense to me that insurance companies, healthcare insurance companies, and auto shouldn't be helping pay for some of these things, right? Because you imagine the comorbidities of accidents and cost and healthcare savings and auto savings if we do more thorough evaluations and be more proactive about our approaches. I think that's a systems problem more than anything. So I think we should be fighting for better coverage of driving evaluations. All right, I'm pulling up the chat here. Is it true that low-dose lithium helps prevent dementia? And the code can be posted in the bottom there. Yeah, there you go. Code's posted. So that's being studied. I haven't heard anything definitive that lithium helps prevent dementia. It's actually been studied in the past too, but it's being restudied right now. I think it's a phase 2 trial right now. So yeah, Richard put a recommendation here. Also recommend to impaired drivers that they design a route utilizing right turns only. That's an interesting one. I like that. Yeah, because basically what you're limiting there is the need to see oncoming traffic with turning, right? That's one aspect of it. Particularly for folks that have vision field cuts and things, those left turns are notoriously the most dangerous, and those are the ones that really get people injured too, because they might misjudge the speed of oncoming traffic. But I think overall, just designing your route is important. So patients are not able to think on the fly as well at early stages. Does Viagra prevent dementia? We don't know. It's being studied. I've had a couple patients, family members ask about marijuana for treatment of dementia. So these are all kind of unrelated questions to driving. Yeah, that is not anything that I'm aware of. There's most studies are looking at CBD for treatment of anxiety and agitation with dementia, not for memory. I don't see any reason why marijuana would help memory, and other than maybe potentially reducing as a sedative, right? But I think the CBD component is more interesting because it doesn't have the hallucinogen effect, and that can cause a lot of paranoia in patients. So CBD seems to be better study right now. Kristen, oh yeah, thank you, Kristen. So Pam Health, okay, so it's down to 300. Good. The charge insurance for the clinical assessment. So Kristen, can you elaborate? So the clinical assessment is your cognitive exam and the processing speed and eye exam stuff, and then the driving is the 300. Is that what you're saying there?
Yeah, that's correct. So
Okay.
most evaluations are done both clinically and behind the wheel, and it's really the behind the wheel piece that's a sticking point for insurance companies.
Yeah.
So they've decided to try to and make it a little bit more achievable for people to be able to engage by charging their medical insurance for the clinical piece.
Perfect. Yeah, no, I think that makes a lot of sense. And then you mentioned here that Hartford pays up to 500 if you've had an accident in the past 3 years. Yeah, no, I think it does that make sense though? Like I feel like auto insurance companies would want these done.
Yeah, I agree wholeheartedly. And I wish that the rest of them would kind of jump on board with that, because it seems like that could be a preventative strategy to try to keep people from continuing to have issues and to identify what the root of the problem might be to assist and make a difference for these folks.
Yeah, absolutely. And one of our nurse practitioners mentioned find starting the driving retirement discussion early and follow-up visits really makes that decision easier as far as when to stop driving retirement. I think that makes a lot of sense. And really that kind of gets back to picking up on things early, having these discussions over time. I mean, I'm usually put in a very awkward position of meeting a patient for the very first time, doing an evaluation, telling them they have Alzheimer's disease, dementia, and telling them they can't drive. It's not a good place to be in a lot of times. So and sometimes I just don't have time to have that last discussion, but I'm going to recommend, against driving and recommend evaluation. And that's going to have to be a discussion back with the PCP or with a follow-up visit at some point in our clinic. But it's so important to start that process early, like you said, Anne. And then Lindsay, another one of our nurse practitioners, mentioned that in Missouri, at least, there is a fund that can be used towards driving evaluation. So yeah, 750 goes a long way. So that would at least get the first evaluation. And then if there's a recommendation for a follow-up, most of that follow-up evaluation. Good to know. Thank you guys. Oh, and Alzheimer's Association provides. Oh, that's who provides the 750. So that is, Lindsay, is that the Missouri State Alzheimer's Association then? I would imagine. Okay. We need to get that in Kansas, huh? Anybody else? Other points of wisdom? Thank you, Kristen. Family Service Fund. Do we need do we need a petition for that in Kansas?
It used to be in Kansas, and I'm not 100% sure. I think it's a grant-based opportunity. So for whatever reason, Kansas no longer has it, which is such a bummer.
Yeah. I used to have a slide at the end on there is a website out there of just like what are the local resources, different shuttles and services, and a lot of communities are stepping up, church related communities as far as shuttle services, and then a lot of the newer assisted living and even independent living communities are having shuttle services, and just recognizing that it's something needed. And I think as we start to implement more and more proactive approaches, that will be an easier discussion of retirement from driving as well, if there are actual options out there, right? Thanks, Anne. Yeah, the state. Who does the state driving eval?
It's just their typical examiners. Sometimes they will have the supervisors do it, but typically it's just their state examiner. So unfortunately, they don't really do a medical component of assessment. They really just take them behind the wheel. And if they can handle the 10-minute drive, they pass them. So that's why it's a little bit more of a risk take to send them to the state. You just never know who you're going to get. And they oftentimes want to just get out of the car quickly.
Yeah.
So they, yeah.
So that's through the DMV essentially then, right?
Yeah.
Okay.
Yeah, and I don't think they're probably as well trained on even having a driving discontinuation conversation with the patients either, So yeah, that's not ideal, but sometimes that's the way we go. There's a couple more hoops you have to jump through. So if you don't get through all the hoops, then sometimes they'll, I don't know if they revoke the license or what, but yeah.
Gotcha.
Yeah.
All right. Well, thank you all I learned a few things as well. So thank you, everyone. Any other, I guess we're over by 1 minute, but yeah, so slides will be posted on EADS. The next two, so actually it's next week, right? We've got Michelle on talking about you've got it on here perfectly, about she's putting together a neuropsychiatric symptoms guidebook in managing dementia. So I'm really excited about that. I think it'll be a really good resource for everyone. And then our last talk will be 2 weeks after that. Dr. Swerdlow is going to be talking about his exciting ketogenics diet studies. So basically therapeutic diets against Alzheimer's disease, comparing heart healthy diet that we recommend right now versus the ketogenic diet. And that'll be a good conversation. So thank you all. I am going to sign off.